Hello and welcome to another session of ASM Live at ICAC. It's coming to you from Chicago, and ICAC is the annual meeting focused on infectious diseases sponsored by the American Society for Microbiology. I'm Jeffrey Fox, the features editor of Microbe, the monthly magazine of the Society, and your host for these sessions. For those of you who are watching over the internet, and when you'd like to ask a question, please use hashtag ICAC, and we'll deal with your question in the room. And if you're in the room and want to ask a question, please raise your hand. Somebody will bring you a microphone, and then identify yourself by name and affiliation. In this session of ASM Live, we'll be talking about the rise and control of gram-negative infections that involve gram-negative bacteria pathogens with drug resistance. And for those of you who aren't sure about what gram-negative pathogens are, we'll get into that as we talk about details. My guests in this session are Mitchell Schwaber of the Israel Ministry of Health in Tel Aviv, immediately to my left, and to his left, David Livermore of the HPA Microbial Services in Colindale in London, United Kingdom. Mitchell, if we could start with you, if you'd give us a brief overview of your talk and some of the highlights of the outbreak you're dealing with in Israel.
Sure. Thank you. I direct the National Center for Infection Control in Israel, which was set up in 2007 to confront an outbreak of carbapenem-resistant Klebsiella pneumoniae. Now, I'll translate that to English. The Klebsiella pneumoniae is a bacteria that's found in the intestines of everybody, and it can, when it gets out of the intestine, it can cause infection in people, wound infections, pneumonia, urinary tract infections, and a variety of other infections ranging from mild to serious and even life-threatening. Until the very end of the last century, we were able to deal with that with antibiotics of various degrees of coverage, as the extended spectrum beta-lactamases in the last 2 decades of the 20th century started to spread. We had to go into bigger guns, broader guns, to treat these infections. But we always had the category of last resort, the carbapenems, to treat those Klebsiella infections that were resistant to everything but. In the first decade of the 21st century was marked by the beginning of spread of carbapenemase-producing Klebsiella. And carbapenemases are enzymes that destroy carbapenems, leaving us with essentially nothing good to treat these bugs. The initial outbreaks were reported in New York City and elsewhere in the eastern United States in the early years of the 21st century. And the bug, we were monitoring for it, and it was on our radar screens. It didn't arrive, at least in a detectable level, until the end of 2005. And at the beginning of 2006, it started to spread through the Israel healthcare system. We know now that this is one clone that's now spread worldwide. It's known as the ST258 clone, and it presumably was imported from America. We have worked in tandem with the CDC that have shown that. But in Israel at the time, in 2006, there was no national mechanism in place to detect something that was going on at the national level. So every hospital had picked up that there were carbapenem-resistant Klebsiella making their way through the hospital. Infection control measures were put into place, and we were still not succeeding in keeping it in check. If you want numbers, I can tell you that in 2006, there were about 700 cases throughout the country's hospital system. And in the first third of 2007, an additional 600. So it picked up steam as it went along. Israel, by numbers, is physically the size of New Jersey, and it has a population of 7.7 million. And it's very dense, and the population is concentrated around the center of the country. Crowded hospitals and a lot of patient movement in back and forth and through the healthcare system. This bug is a triple threat. It's highly resistant, spreads very effectively, and is a killer. The crude mortality for being affected by this bug was 40%. So we were established in 2007 to confront this threat to the healthcare system at the national level. And my talk today focused on what we've done since 2007 to confront it.
Okay, thank you. David.
I've been talking more broadly on the rise of gram-negative pathogens or resistance in gram-negative pathogens. And I tried very much to make the point that these are critically important organisms. E. coli accounts for 80% of urinary tract infections. It accounts for 20% of bacteremias. If you look at seriously ill patients in hospital, something like 40% of the infections are caused by Enterobacteriaceae. That includes E. coli, includes Klebsiella, both gram-negatives, another 10% or so Pseudomonas. These are bacteria that have been getting more resistant. Through the first few years of this century, there was a move, particularly in E. coli, that commonest gram-negative, to more resistance to cephalosporins and quinolones. And exactly as Mitch has described, that's driven wider use of carbapenems, previously our reserve antibiotics. The real last powerful drug to be used for difficult infections. We've been forced to use them more and to use them earlier. And that in turn has been selecting for resistance. Resistance includes the KPC type resistance that Mitch has just been outlining, but internationally, other carbapenem destroying enzymes, or carbapenemases we call them, emerging. Vim spreading from Greece, OXA48 spreading from Turkey, along down through the Levant, the North Africa coast, and then into Europe. And then an enzyme that was in the headlines last year, NDM, New Delhi Metallo, originated either in India or Pakistan, imported into Europe, into North America, and into the Far East. So really a hydra-headed threat, a multiple threat emerging to one of our last really good anti-gram-negative antibiotics. So a serious concern there. And that links to two other points, that some of this threat, not all of it, the KPC came out of the United States, but some of the threat comes out of what are fast-developing countries like India or OXA48 from Turkey, countries that are getting wealthier, whose citizens very rightly are expecting better health care. There's a rapid development of hospitals and of quality medicine, sitting, particularly in India's case, on a water infrastructure that doesn't work, that allows the recirculation of resistant bacteria from sewage to people's guts back into the hospitals. So a major concern there on public health issues and how resistant bacteria are recirculated. And what then exacerbates the whole issue is the shortage of new antibiotics coming against gram-negative bacteria. We've very little in the drug pipeline expected to be launched in the next few years that is going to be reliably active against all these diverse carbapenemase threats from KPC to NDM.
Well, this might be a good time because we are speaking exclusively about gram-negative pathogens to define them for people who may not be familiar with that term, and maybe in doing that give us a sense of why they present such a challenge in terms of developing drugs that combat them?
Absolutely. Bacteria divide into two great families, gram-positive, gram-negative. It's a division that's based on a simple laboratory stain that was developed by a German microbiologist called Gram about 120 years ago now. Fundamentally, though, his stain, or the behavior of bacteria in the stain, depends upon their cell wall. Gram-positive bacteria have a rather simple, thick but simple cell wall. It's quite easy to get antibiotics through that cell wall. Gram-negative bacteria, includes E. coli, Klebsiella, Pseudomonas, have a more complicated cell wall structure. That's what makes them gram-negative. And it's harder to get antibiotics in. First, you've got to get the antibiotic through that cell wall structure. That's the first problem. And the second issue is that gram-negative bacteria are very good at pumping antibiotics back out again. So getting an antibiotic in, getting it to stay in the bacteria, poison the target, kill the bacteria, is much, much harder with gram-negatives like E. coli and Klebsiella than it is with gram-positives like MRSA.
I might just add one word from an infection control point of view. Along the lines of what David just said, once we're in the kingdom of gram-negatives, we divide them in the hospital between Enterobacteriaceae, the gut flora, and the non-fermenters. It's not just in the hospital, but people doing hospital-based infection control, that's a very neat divider because both kinds, the non-fermenters, which are the important ones for us, are Pseudomonas and Acinetobacter, are found in specific areas in the hospital, often in ventilated units, in intensive care units, in advanced care units that are not really categorized as intensive care, but we know where to look for them geographically in the hospital. But they present a problem because it's hard to look for them on the person. There's no reliable space in the person where you can swab it, and if it's there, you know it's, well, if it's there, you know it's there, but if it's not there, you're not sure that it's not somewhere else. The Enterobacteriaceae, the gut flora, E. coli, Klebsiella, Enterobacter proteus are the four big ones as far as we're concerned in the hospital. Those we can look for in the gut by taking a rectal swab and plating it out, looking for it according to the best methods that, Dr. Livermore and his colleagues tell us to do. So there, it's a very, very valuable tool, active surveillance from the gut in terms of planning and implementing infection control interventions.
But harder, surely, because if you find somebody has got MRSA living in their nose, and the nose is the common place for MRSA to live, you can do something about it. You can use mupirocin or a drug like that to decolonize the nose. If you find that you've got somebody carrying KPC Klebsiella in their gut, all you can do is barrier precautions to minimize the possibility of it being passed to somebody else in the hospital. You can't surely decolonize. You can't get rid of it from the gut, or at least you can't get rid of it quickly. Right.
The whole search and destroy philosophy for MRSA doesn't work here, but search and identify in order to do it precisely as you say, to critically, in as timely a manner as possible, identify these carriers, isolate them, dedicate equipment and nursing staff to them is pivotal in containing outbreaks.
Let me just intervene and say that MRSA is, for those of you who may not be familiar with it, methicillin-resistant Staphylococcus aureus. I just passed some kind of simple exam here. Let's go on and talk, let's get back to the gram-negatives, and tell us some about what you're doing in Israel and some of the problems you're wrestling with in terms of controlling this outbreak that began in the mid-2000s. Where have you gotten to? What is effective, what isn't? Are there some general lessons that are applicable in other parts of the world, or is your situation unique?
well, everybody likes to think their situation's unique, but I think that there's some very valuable lessons because the world can now be divided into two types of areas: those where the KPCs have arrived, the carbopentamases have arrived, and those where they haven't yet arrived, but they're on the march. I think this particular bug, this particular ST258 clone of Klebsiella, is extremely efficient at spreading in healthcare settings, in acute healthcare settings. And so, this was known even before it arrived in Israel. New York City has been dealing with outbreaks with similar numbers to what we have seen. What happened once the health ministry became aware that this was going on and threatening the entire healthcare system, and when I say threatening, I'm not using that word lightly. When you have a bug that spreads so efficiently in a hospital setting, you can very quickly, in the matter of days, overrun an ICU. And if you overrun an ICU, then you have to stop doing elective surgery. If there's nothing useful you can give as antibiotic prophylaxis, if there's nothing useful you can use to treat a post-operative infection, then you have to think twice about every patient you allow to come in electively. Literally, the entire healthcare system was at risk here. What the health ministry did was two things simultaneously in March 2007. They issued guidelines, compulsory guidelines to the hospitals saying anybody that you have identified with this bug, okay, we called it carbapenem-resistant Enterobacteriaceae. We now know that 90% of those were this Klebsiella strain, had to be physically separated, either in isolation rooms or in what we call cohorts, hospitalized only with other carriers. They had equipment that was just theirs. Any equipment that had to be shared with non-carriers, there were specific procedures to clean it before it would go out. And more than that, the nursing staff who treated these patients on a given shift would not treat non-carriers. So there was what's called dedicated nursing staff. At each shift, any nurse who treated them didn't treat others. These were put into place in March 2007. And the other thing we did was to set up a task force. And the task force consisted of a doctor, a nurse, and a microbiologist to oversee the implementation of these guidelines, go from hospital to hospital, get the information electronically from every hospital, and make sure that everybody was doing what they were supposed to be doing.
All right, and that was sufficient, or that's helping to control the...
Absolutely. In fact, it's turned out to be necessary. The steady rise that I described before with it picking up steam in the early part of 2000 was brought to a halt immediately with the implementation of the first phase of the guidelines, the isolation, cohorting, and dedicated nursing staff. That was in March 2007. In May, the task force set out and started working among the hospitals and gathering the information. And the trend reversed, and we saw a downturn that we showed statistically significant downturn in the new acquisitions by clinical culture month to month over time. We continue to fight this every day. We get information about every carrier in the hospital system on a daily basis and their levels of compliance, well, the hospital's levels of compliance with the guidelines. We track their movements. If they leave the hospital, if they go home, we know it. If they go to another facility, we know that, and make sure that the other facility knows to isolate them. So that we have a picture in real time, all the time, and know where we need to intervene. Midway through, about mid-2008, it became apparent that doing all the right things by all the known carriers is good, is necessary, but it's not enough. You also have to find the silent carriers that you don't know about, but are carrying it and are potential sources of spread. And so we implemented guidelines based on assembled data as of that time for active surveillance of high-risk groups, meaning patients who would undergo rectal swabbing to look for those bugs, where, again, anybody who was found to be positive was put in the same isolation cohorts as the known carriers.
Right. David, you...
I think it makes an absolutely, what you're describing, Mitch, makes an absolutely fascinating contrast to Greece, where exactly the same sequence type 258 Klebsiella pneumoniae with KPC has got in. It got into Greece sometime around 2008, possibly a little bit later than Israel, into a country which already had a carbapenem resistance problem with Klebsiella with Vim. And KPC has gone up, and it's now about 40% of all Klebsiella, at least from bloodstream infections, have got KPC. So this has gone to a stable, high rate, whereas in Israel, under a really rather national, really very rigorous mandated infection control program, it has proved possible to bring it down. Do you think the type of policy that you describe is exportable to other healthcare systems which are organized very differently?
I think it's an excellent point, and it's an excellent question, and I don't know, it really depends on the healthcare system. There's no question that in order to effectively carry this out, there had to be national mobilization, and our task force had to be invested with the authority in which it was to solicit the data from the hospitals and to intervene when necessary with the backing of the health ministry higher-ups to enforce policy when necessary. I can say that compliance has shown to be effective. The more patients you have who are carriers, unchecked, the more you will have. The higher the number of carriers, the more new carriers there's going to be, unless you step in and do and take the measures that we've talked about. We've shown that when you take those measures, you neutralize the relationship between prevalence and new incidence. But if you don't take those measures, it continues unchecked. And if you do something halfway, then it continues sort of halfway unchecked. There's a very clear connection. In order to carry this out effectively, it has to be enforceable across the boards, and any healthcare system that is capable of implementing policy across the boards should do so if confronted with this type of bacteria. But I understand from my Greek colleagues that this morning that the Greeks are taking steps in that direction.
One thing I really am baffled by or don't understand is why, which is a good, one of the positive things here is that this resistance trait seems to be limited to Klebsiella. It's not moving from it into other gram-negative.
No, I don't think that's quite true. What you have is a resistance trait, carbapenem resistance, and there's a range of different enzymes that can give that resistance, of which one of those is KPC. Now that is on plasmids which have moved about between different strains of Klebsiella, of E. coli, and of Enterobacter, and a few other species as well. But among other things, among other hosts, it's moved into this particular strain, sequence type 258, and that combination, it seems, of a Klebsiella that's very good and fit and good at spreading among people, and the resistance, then suddenly you've got a lethal combination of fit bug with potent resistance. But KPC itself, the resistance gene, is spreading more widely. At present in the United Kingdom, we have an issue in the northwest of England where our problem is that plasmids coding for KPC are not in sequence type 258, but they're spreading among lots of different strains of Klebsiella. We live in a great and evolving genetic soup where resistance mechanisms come together on loops of DNA called plasmids that can move among bacteria. Genes are gained, lost from plasmids. Plasmids move into different bacteria. But just sometimes you get a plasmid that moves into a very fit, potentially very successful strain, and that's exactly what Mitch has described with 258, which has been so successful in Israel and then latterly has been brought under some control.
So there's something sensational, very potent about this combination in Klebsiella. Okay. We have a question from the internet.
Yeah, actually, I think this sort of ties in with what you've just been talking about. Jesse in our chat room on Ustream wants to know what facilitates the easy spread of this organism in the healthcare setting.
You want to take it, or should I? Okay, I can tell you crowded conditions, for one thing. We can back up because I think it's an excellent question. First of all, these bugs are strong on the weak. They are typically attacking those who are hospitalized, and not just everybody who's hospitalized, but people who are in ICU settings, people who are receiving antibiotics, people who are in some way or many ways debilitated. They do not, at this moment, pose immediate threat to the general public. That's not to say that they won't, that we won't see evolving epidemiology where one day they will, but at the moment, these are the patients who are at risk. And if everybody in the hospital setting, every staff member, every family member, did exactly 100% of what they're supposed to do at any given moment, we wouldn't need contact isolation, we wouldn't need cohorting, we wouldn't need dedicated staffing. If you always performed hand hygiene properly, if you never allowed material equipment to touch from one patient to another, if a nurse leaning over to assist a patient sitting up in bed would be careful not to have her gown, her clothes, then touch the next bed, there would be no need for that, for the additional measures. But the fact is, it's not possible to do 100% all the time. So that's why for certain bugs, for certain pathogens, we add other measures. So for antibiotic-resistant drugs, we put gowns on when we treat the patients and then dispose of those gowns after we're done. We put gloves on similarly and then dispose of the gloves and then perform hand hygiene before we move on to the next patient. Even in those enhanced settings, if the beds are crowded, if there's not adequate space, if, like we are in the Middle East, families don't just come to see their own loved one, they help out with the neighbor in the neighboring bed and help give him food. They go to the nurse's station to ask about their loved ones and bring the flora that were on the patient's bed up to the nurse's station. This kind of bug just jumps into those hoops. It jumps into those windows of opportunity that are created for spread. When you have a bug that is so efficient at spreading, it doesn't forgive anything. If you do 99% of what you're supposed to do, but not 100%, that 1% will be taken advantage of by the bug to spread. So there's so many opportunities for transmission, even with the safeguards that we have in place for normal multi-drug resistant organisms, that we were forced to put even more draconian measures into place to check spread.
I'd absolutely agree. It's breakdowns of infection control at hospitals allow spread of organisms. It's the fact that we have more very elderly, very sick, very vulnerable people who are hosts for these organisms. Many of them routinely live in nursing homes and care homes where the infection control cannot be as tight or as rigorous as at hospitals. All this adds up to creating opportunities, and nature abhors a vacuum. So organisms evolve that are capable of this type of spread among patients, and the fact we give them an expanding ecological niche in the way that we run healthcare and in the way that we can keep people alive with underlying disease which half a century ago would have been unthinkable.
We have a second sort of related question from another viewer in our chat room, and I'm going to sort of paraphrase it because in addition to the strategies that you've already described, are there any other additional strategies to control and prevent this rise in resistance?
Well, I think it depends very much on the type of resistance and how it's being spread. The sequence type 258 Klebsiella, which Mitch has concentrated on and has caused such a problem in Israel, really is a person-to-person transmission, substantially within the hospitals. Classic hospital infection control has to be a major factor there for stopping spread. But if you say, look at a different carbapenemase, NDM in India, what's happening there is that plasmids are transferring the resistance from one bacterium to another, from one species to another. The resistant bacteria are circulating in contaminated waters outside the hospital and being carried in to hospitals. If crossing into Pakistan, one study that we've recently done with John Perry and colleagues and collaborators in Rawalpindi in Pakistan, showing that 14% of outpatients had carbapenemase NDM-producing bacteria in their gut. What's critical there is improvements of infrastructure, providing people with clean water, making sure that resistant bacteria can't circulate to this extent outside the hospital. Because very surely, if we don't do that, we keep feeding resistant bacteria into the hospital with the patients, the food, the staff that go in, then the type of infection control that Mitch describes becomes a never-ending nightmare, an impossibility.
And then there's the whole arena of judicious use of antibiotics, antibiotic stewardship, which David mentioned at the very beginning that the field was ripe for the spread of a carbapenem-resistant bug when so much carbapenems were in use as a result of the previous generation of resistance, which was creating bugs that were resistant to everything but carbapenems. We have this constant loop of the bugs develop resistance, so we become more broad spectrum, and then that creates an environment that's favorable to the fittest, to those bugs that have acquired resistance. And so then we ratchet it up a notch, but so do the bugs. So it's very easy to say judicious use of antibiotics and antibiotic stewardship. It's much more difficult to carry out when you have a patient with a bug or you have a patient who comes in with an infection in an environment where a high proportion of the pathogens are resistant. It can be very difficult not to use the biggest gun you have to treat that patient empirically. And then when you get the result, if it's a resistant bug, then of course you have to go on with what you have. If it's not a resistant bug, you can and you should narrow the spectrum, but if the patient's doing well, it's a hard call to change the antibiotic when the patient who was so sick is now doing well. This is something that needs to be given a lot of thought to by policy planners, by people who understand the nature of antibiotic use and how it should be done. And that is without even touching on the whole nature of antibiotic use in growth promoters in agriculture, which is a huge part of the problem also in terms of creating an environment that is very favorable to resistant bugs.
Yeah, I'd absolutely agree, and I would say 5 headlines. 1, use antibiotics less, both in people and in animals. 2, use them better. Use an antibiotic that's likely to work, that does the least damage to the rest of the bacteria living in somebody's gut. Thirdly, infection control, everything from the sort of thing that Mitch has talked about through to using condoms to stop the spread of resistant gonorrhea, another gram-negative bacterium. 4th, development of new antibiotics is critical. 5th and last, and again latching back to what Mitch has just been saying, is improved diagnostics. I think it's one of the great embarrassments to us as microbiologists that our speciality still works at the speed it did in Fleming's day. Got a sick patient? Get a specimen, urine or whatever, one day to isolate the bacteria, another day to test what antibiotics they're sensitive or resistant to. That's 2 days in which the patient is on some antibiotic, maybe the wrong antibiotic, maybe a very broad spectrum antibiotic that's selecting for lots of other resistance in their gut. If only we can make the microbiology much faster, efficiently looking for resistance at a genetic level. Patient can be put on the right antibiotic earlier. That's good for them. And antibiotics can be used better at a society level, which is better for the common good.
We have a question over on this side of the room, Jim.
Joanna Lum, I'm a freelance writer from England. From what you have just said then, what possibility for improved, quicker diagnostics, genetic testing?
I believe it is gradually coming. Roche had a prototype system called Septifast, which could be used on blood at least to identify over about 6 to 8 hours what the type of bacteria were, and if it was Staph aureus, whether it was MRSA or not. I think the system needed some refinement, but I think as a pointer on the direction to go, it's right. It gets harder once you go outside blood, though. Your blood should be sterile. So physician draws blood, looks for bacteria in it, finds bacteria, finds a resistance gene. You can be pretty sure that that's the bacteria giving you sepsis, and the bacteria are the ones that have got that resistance gene. It becomes much, much harder if you start trying to look at urine or sputa where there are going to be other bacteria there. So it's a challenge to find the right bacterium, the one that's causing the infection, and to tie up the resistance gene. You'll find lots of resistance genes from other contaminating bacteria, to tie up the resistance gene with the particular bacterium that's causing the infection. So I think it's going to come, but it's going to come step by step. And there are systems there that at least point out the way.
May I just ask one more thing about the new drugs? I think from what Dr. Livermore, you were just saying, it's harder to get a new drug that's going to work against gram-negative.
Correct.
And you've said there aren't any coming along in the short term. At the session yesterday, when they talked about the even earlier ones, were you encouraged by what you were hearing about the new drugs?
There are a few drugs. What I said, and let me just clarify, was that there was nothing in advanced development that covered all the problems that we now face. There are drugs like avibactam combined with ceftazidime or ceftaroline. The ceftazidime combination is in phase 3. That's a potential answer to the KPC problem. Ceftazidime plus avibactam is active against most bacteria with KPC. However, it doesn't cover other types of carbapenem resistance like NDM. If you go back to drugs in phase 1, just going into phase 2, Glaxo have got, together with Anacor, a series of boron-based antibiotics, which do look to have a very broad spectrum. But you're talking drugs there that are maybe 4 years away. There are the new tetracycline analogues that Tetraphase is looking at. They too, probably 4 years away. Again, a very broad spectrum that would include bacteria with NDM as well as those with KPC. And there's other areas of interest. Ribex have got a new series of protein synthesis inhibitors that were highlighted at yesterday's session as having a broad spectrum. Wait to see the posters on those on Tuesday, but from the review summary, they certainly sounded to be an interesting series of analogues. But remember, I'm talking now of drugs that are several years away. We can't be certain that they're going to get smoothly through all their clinical trials, and we have to wait and see just how efficacious they are in infections caused by some of these most resistant bacteria.
All right, I think Oh, Mitch, you have
like to,
a comment.
One comment in closing, just sort of my take-home message. Antibiotic-resistant bacteria are here now to stay. They're part of the landscape, and we are dealing with tactical and important tactical moves and some strategic moves, but we have to accept the fact that they are here, and we have to brace to incorporate approaching them at every level of healthcare, from the public health, prevention, down to the therapeutic at the bedside levels. One aspect of learning from the Israeli experience is not just doing what we did right once we picked it up, but not being in the situation we found ourselves in at the beginning of 2007, where this epidemic was raging under our noses without a national level, a national mechanism to detect it. The surveillance, it's out there, it's here. The surveillance has to be in place to pick these bugs up when they arrive and to nip their spread in the bud.
And surely, I would absolutely agree with that point, but you're describing the experience based on one small, developed country with quite tight public health controls. Think for a moment of places like India and China, which collectively account for 1/3 of the world's population, which already have some of the biggest resistance problems and simultaneously some of the fastest developing tertiary care medicine in the world. The potential for a resistance catastrophe there is huge.
Well, let's end on that grand and that takes the wind out of our optimistic sails from the last several sessions, but that's all right. We want to be balanced in terms of our optimism and pessimism. I've been talking with Mitch Schwaber of the Israel Ministry of Health and David Livermore of HPA Microbial Services, Colindale, London. We've been talking about multiple drug resistance in gram-negative pathogens. That ends our sessions of ASM Live at ICAC for Sunday. We have a few more scheduled for tomorrow. Please join us then, and thanks for being with us now. Thanks. Okay. Thanks very much.
Thank you very much. Enjoyed it.